final track. Healthcare has been the most consequential of all the incredible changes, the one that ushered in all the rest. Let's welcome our moderator, Dr. June David.
Hi guys, good evening. So thank you for attending our mini conference, and I would like you to make sure that and we have our two leaders that we're gonna have, and one of them is the Dr. Legaspi. Dr. Gerard Legaspi is the PGX director, and we also have Dr. Lou Publico, who is the current president of the UP Medical Alumni Society in America, or called UPMASA.
Today, may I share with you some incredible developments driven by artificial intelligence, robotics, 3D printing, the progress in cancer research and other therapeutics, how healthcare is being accessed, and conclude with breakthroughs in smoking cessation and the promise of universal health care. Transplant medicine has exploded. Now the blind can see, the deaf can hear, and even the face can be transplanted. It used to be said that I think, therefore I am. Now some patients say, I think, therefore I do. And this is because of some brain sensors that allows a robot to do the action. Artificial intelligence and robotics have driven remarkable developments in healthcare, from keeping well through decision-making all the way to end-of-life care. Early diagnosis is made possible by the use of biomarkers and the development of sophisticated imaging, such as functional MRI, and the development of sophisticated PET scans that can visualize and measure changes in metabolic processes and other physiologic activities, including blood flow. mRNA technology has been in development for decades. It provides us a recipe that our cells can produce protein. So it was really fortuitous that when COVID-19 hit, the mRNA vaccine can be developed in record time. Early diagnosis is made possible for a cancer. The biomarkers can either be answering questions like, is it likely to develop cancer? What type of cancer is it? Is this the optimal drug for my cancer? What's the optimal dose for my body? And will the cancer return? The use of engineering tool like CRISPR lets scientists cut and insert small places of DNA at precise areas, enabling them to study our genes in a specific targeted way. And this will probably lead us to precision medicine. The All of Us research program is a historic effort that involves a cohort of 1 million volunteers that includes me from around the US who provide genetic data, biological samples, and other information about our health. This encourages open data sharing, data that is used to study a large range of diseases with the goals of better predicting disease risk and understanding how disease occur. Since the Cancer Moonshot launch in 2016, the cancer community has made measurable progress toward 3 ambitious goals: accelerate scientific discovery, foster greater collaboration, and improve the sharing of cancer data. President Biden, last September 12 at the JFK Presidential Library and Museum in Boston, delivered his bold vision, ending cancer as we know it, a vision that will change people's lives for the better, improve their health, and decrease the burden of the disease. What about other interventions? Deep brain stimulation has been approved for essential tremor in Parkinson's disease since 1997, and recently for other conditions as well. Do you see the patient playing violin while tremor is being controlled? A recent article in the New York Times asks if robots are the answer to nursing home care. They make rounds in the several facilities where they socialize with the residents, tell jokes, and lead yoga classes. On the other side of the is the Da Vinci surgical robot, a similar one used for one of my colleagues as her adrenals were removed. Virtual reality application in rehabilitation has improved training that requires a lot of repetition. Some applications allow a patient to go through daily living tasks, like food shopping, with song played in the background. I imagine one in a local palengke, shopping to the tune of Bahay Kubo or Paro-Parong Bukid. It used to be most challenging and frustrating to fit artificial hands to children with missing limbs. They were expensive, tended to be heavy, needed frequent replacement. With the advent of 3D printing, Iron Man Tony Stark is joined by many children, fitted with easy-to-assemble 3D hand prostheses that are colorful and adaptable to many conditions. Children and their families have been given a new lease in life, as the hand can grasp and hold, can move underwater, can even do fist bumps. The last decade has also introduced a sophisticated and continuously evolving electronic medical record. Most of us use Epic. And with MyChart, patients can now view their lab and imaging reports, their clinicians' comments and instructions. This has upgraded patient-doctor relationship in many ways. Virtual meetings via Zoom, such as what we're having now, continue to be a practical way to host meetings and conferences. CME courses offer virtual attendance all over the globe at various time zones. This is a real breakthrough in rural settings, because now a house call means telehealth or telemedicine, even telerehabilitation. So those from the rural areas don't have to spend 1 hour on the train with a 30 to 45-minute wait. And even now, millions of us wear our hearts not on our sleeves but our wrists, where we can track our heart rate and rhythm, count the number of steps walked, calories burned, oxygen consumed, in a small gadget that also tells time and even records emails and text messages. I would like to end with recent developments in smoking cessation efforts. Tobacco is deadly, we know that. And the important breakthroughs since the Great American Smoke Out that began in the 1970s include a combination of behavioral counseling, nicotine replacement, toll-free quit lines, web-based interventions like becomeanx.com. But I agree with my colleague in Guam, Dr. Annette David, that evidence-based policy interventions have been proven to reduce tobacco use. Summarized in the acronym EMPOWER are the key elements contained in the WHO Framework Convention on Tobacco Control. It's the first global public health treaty established in 2003. It was in 2005 when the Philippines ratifies the FCTC. In the US, smoking has decreased from 21 to 12.5% among adults and from 20 to 6% among the youth. The Philippines is even more dramatic, from 28 to 16% among adults and among the youth from 22.7 to 12.5%. It is thus very clear that it takes policies, laws, governmental intervention to make a substantial impact in the war against smoking. Those billboards of Marlboro Man need to come down if they haven't yet. Access to health care in the US depends on third-party payers through one's employer or Medicare, Medicaid. It's good those with pre-existing conditions are now covered. However, In the area of universal health care, in the United States, as late as today, it is still being debated and or explored. The Philippines seem to be way ahead, as it has passed the Universal Health Care Act of 2019 to ensure Filipinos have equitable access to quality health services and avoid high out-of-pocket expenses. It would certainly be great to hear the latest from what Dr. Legaspi has to say. Maraming salamat at mabuhay po tayong lahat.
Thank you, Dr. Publico. There's a lot of things you discussed here. And of course, my interest and my colleagues' interest is the transfer of technology to the Philippines. What do you think about that?
Yes. Can you hear me?
Yes.
Well, UPMASA, the University of the Philippines Medical Alumni Society in America, I think is the best platform where we are able to share expertise from the US to the Philippines. We are very active in promoting transfer of knowledge. We have the Visiting Teachers Program, where back in 2019, we were able to send a visiting teacher who talked about blended learning. And this was very timely because soon after, the pandemic hit, and the College of Medicine was able to use what was learned by the teaching of the visiting teacher. As late as last week, we also got some requests from the Department of Obstetrics in PGH about a need for a particular skill that our visiting teacher will most likely be able to answer. In terms of other forms of technology, I pointed out the Da Vinci robot, which I think PGH has, and the first patient that was the beneficiary of this technology also was because of a visiting teacher, Dr. Ian. I think Dr. Legaspi will be able to say a little bit more about how we have been able to assist PGH in many ways in terms of transfer of skills and technology.
Thank you, Dr. Publico. You did mention about electronic medical records, and a good example is Epic, and including my practice, we are basically doing paperless technology in our clinics. However, the American Medical Association and a lot of medical organizations are really concerned about burnout amongst American doctors. And one of the main sources of burnout is electronic medical records. Can you comment about that?
Yes, as a matter of fact, in my own hospital, when we decided to go electronic, at least 2 or 3 of my colleagues who were of a certain age decided to retire instead of even learning how to type. But I think in the Philippines, if I am right, and I'm sure Dr. Legaspi will correct me, during the pandemic, they were able to go electronic. So I understand that they are now using laptops or iPads when they make rounds. But in terms of burnout, I think Epic, there is always a learning curve. So for example, they continue to improve so that it becomes more user-friendly. And at least in my hospital, that's the only way we move now, is through electronic medical record. And I think it's here to stay.
Thank you, Dr. Publico. May we now ask with the video for Dr. Legaspi, please?
Good evening, everyone. Good morning for us here in the Philippines. It's my pleasure to join you and share with you some of our perspectives in the incredible changes of the 2020s in healthcare. The lessons that we learned from the pandemic also should be used as a guide to help us move forward from this very difficult situation that we're all in now, but nevertheless, all hopeful for a better healthcare system for everyone, most especially our patients. The strategic intelligence put forward by the World Economic Foundation has mentioned 5 areas in healthcare that we are that are worth looking into: preserving health, maintaining it, enabling access to everyone, improving into technology, and of course, prepare again for the inevitable next pandemic, as people predict. But for us here in the Philippine General Hospital, and maybe for the country in general, we are looking at 3 areas where in the last 3 years, incredible changes have happened and are still going to happen, hopefully, and covering a wide area of programs, not only in the hospital, but also in the community. And these are the 3 laws that put provisions for delivery of the universal health care, of cancer care, and of course, training more health professionals in the future. For universal health care, that was signed into law by President Duterte in February 2019, the 3 prominent paradigm shifts that we see are those that shift our orientation to healthcare as we know it here, shifting to the true primary care paradigm, reaching every patient as much as we could. Also providing every service that they need in a healthcare provider network funded by the government, and this is going to be a big challenge for a struggling financially struggling government at this point. But making sense of all that is the newly created health technology assistance to make sure that we pay only for what's right in giving this service for our patients. So these are the prominent features of this Universal Healthcare Act. And so by far, in the very important transitory provision, there are low-hanging fruits that we have already picked, so to speak, and including the creation of a new PhilHealth board, which was a bit of a challenging situation for us in the last 2 years, but now improving. And of course, and the creation of the Health Technology Assessment Council, which is headed by our own Dean Marita Reyes, and we're really thankful for that. She's doing a very good job there, quite challenging as well. And of course, the funding transfers from the Philippine Charity Sweepstakes Office, which made the Malasakit centers function as they should in the last 3 years as well. The beginning transitory process of the local government units integrating management and financial systems also have started, as well as certifying of our primary care providers. We are still far from the timeline that we've set for ourselves in as far as this act is concerned, but at least the provisions for the funding of the outpatient consultation have been there already in December 2021. Policies have been printed and published. And of course, the more important part now is how to make this a truly functioning network care, wherein our orientation to our patients, not only the one in front of us, but now as part of our whole national wide system, access to any care in any part of the country. And since we all know that the funds are not infinite, there also has to be some kind of a system that we need to make sure is in effect, so that the efficient use of these funds are set into motion. And one such part of the bill is the creation of the consulta capitation budget, meaning where outpatient families are given specific financial assistance for outpatient consults, and this is proving to be very effective for us in our outpatient services as well. So things are moving on in network care, and the LGUs are getting a lot of support from the government. Slowly, it's being threshed out in pilot areas, and I think one of the biggest factor here the success of this program compared to the others is the big engagement of private healthcare providers. No? The private sector is very keen on healthcare involvement in the government and PGH included, and they have used the provisions of the Universal Healthcare Act in their own structure in providing for their private patients in their own network as well. Of course, all of this is backbone of an information system now being piloted in 3 sites created by our own Dr. Tony Dance when the DOH, PhilHealth, and UP agreed to combine forces and pursue the Philippine primary care studies. 3 sites now where this is being piloted, and soon I think it'll be in 9 other sites, one in Bataan, the Diliman, and Sorsogon. So as far as the Philippine General Hospital is concerned, we also have instituted our pilot engagements with our primary care providers in Mabini, Batangas, in Samal in Bataan, Santa Ana Hospital in Manila, and we have now signed a memorandum of agreement with 9 provincial provinces making us their healthcare apex hospital. So I hope this continues on and we cover more areas in the spirit of this Universal Healthcare Act. So the current status of the Healthcare Act is now in the financial integration of the local health systems among LGUs that committed to engaging the provisions of this law into their healthcare delivery system. And this will be a big challenge, as I said, because of the financial status of our country. But I think the pilot studies are proving to be quite, they're very optimistic that the system will work. So the question now is, how do we provide all the advanced technological health services, being a primary care-based system, to all of this? And I think this is where the hospitals will come in, most importantly, the government hospitals. And how do you provide all of this and make them available to all the stakeholders that will need them? The Department of Health is a public health facility development program that aims to bring specialty services to different parts of the country, expanding a health center, the NKT, National Kidney Center, the Lung Center, and all the specialty centers that they have. PGH is not part of the Department of Health. Unfortunately, we're not part of that system, so we have to create our own National Health Development Program, which I think is a topic for another meeting. So after the Universal Healthcare Act, just around the same time, the President also signed the National Integrated Cancer Control Act, which has so far committed 500 million for financial assistance for patients. This is not on a nationwide basis, and almost ₱1 billion a year for patients to have access to free chemotherapeutic agents and medications. The guidelines for Cancer Network and the Philippine Cancer Center are now being formulated, and before I left, the Secretary of Health, the OIC, has asked me for a meeting to discuss the role of PGH in the creation of the Philippine Cancer Center. The first successful Department of Health and Department of Trade and Industry price negotiation for trastuzumab to be more accessible under the NICA and the UHC law has been done, and this will provide more coverage for our breast cancer patients. And clinical practice guidelines are now underway. And of course, all of these developments will not be successful without the people who make them run and doctors being having the primary role in this whole endeavor. In December 2020, President Duterte again signed the Dr. Para sa Bayan Act. And to summarize that, it aims to provide medical scholarships and institute a return of service agreement program in state universities and colleges all over the country. This is in partnership with the Commission on Higher Education. Before this program, there are only, I think, less than 10 state universities with medical schools. Now there are 15 as of 2022. And hopefully, as we roll out this program, put more money into it, get more students interested, we'll be able to meet the demands of our population. Currently, our doctor-to-patient ratio is 3.75 to 10,000, when we need 10 doctors for every 10,000 population. So there's a long way to go, but we're getting there. The important provisions now to ensure plantilla posts for our doctors, not only while they are training, while they are studying, but also during their training and after they graduate. So the whole of career coverage by this program hopefully will encourage more of our doctors to serve our countrymen and stay in the Philippines. And the schools that have started the programs are now going to be assessed every 5 years, and the goals for more doctors to be educated, calibrated as to the need of the population. So we have just seen some mega trends and touched on the network services, integration of our healthcare service, the hub and spoke model, and the development of our health professionals, the financing of healthcare, the role of private sector, much like we are doing now with our cancer center, and of course the very vital part that the information technology plays in all of this. So in summary, for the universal healthcare, we are trying to reach everyone with limited resources, requiring systems for budgeted networks and network care. A lofty ambition, but I think doable with the proper implementation of the rules and regulations. The Cancer Act is also running its course quite slowly, but as we engage the private sector more, I think the rate of success in bringing this service to our countrymen will go higher, as we are doing with the cancer center in the Philippine General Hospital. The long-term problems that require long-term solutions, targeting every stage of the issue, is being done with our Dr. Para sa Bayan Act. And since even if return of service is implemented, it's just a start. I think what will require is that for the rest of the system is for the doctors to be retained, is that we support them and work with the strengthened pipelines graduates. So thank you very much. I hope I can now take in your questions.
Dr. Legaspi and of course Dr. Publico, we will now proceed with some questions that was submitted to the chat box. And this is for you, Dr. Legaspi. This is from Dr. Leonidas from the Philippines. How can PGH help reduce diagnostic errors below 10 to 20%?
Well, the role of PGH really as a hospital is to teach as part of its two main functions, teach and serve. I think the teaching of the avoiding of diagnostic errors starts from teaching our students about it, and the residents and the fellows who pass through the hospital. As far as the system-wise, our patient safety unit, which was put up with the help of UPMASA through Dr. Vic Malabonga and continues to be very active now, is now laying down processes in terms of prescription, laying down instructions on how to write these prescriptions on our electronic medical record, and of course ensuring that the data that is found in the patient's charts every day pertaining to the lab tests done and even the prescriptions that are being done are consistent on a day-to-day basis based on the program put in our electronic medical record. So I think the important steps are being taken now, and these are all now based on information technology.
Thank you, Dr. Legaspi. How about you, Dr. Publico? You have any thoughts about cutting down diagnostic errors?
Well, as Gap has just said, number one is to educate, but the more important part always is systems. Like even in therapeutics, it's always systems. So for example, it used to be that, especially during the HIV crisis, you can poke your finger with a needle. But when they used technology and they used systems, then they made sure that this is prevented by making sure that the needles are no longer, you cannot recap them. And again, I'm so glad that Gap mentioned Vic Malabonga's stint as a visiting teacher, because that was the main purpose of his being there, is to set up the patient safety unit. I'm so glad it's working.
Thank you, Dr. Publico. There's another question here. I think the way it's stated is, how do Filipino doctors help the Filipinos in the Philippines?
Well, the Filipino doctors in the United States, you mean? Well, like those of us who are supposed to be scholars ng bayan, who are supposed to have stayed home in the Philippines, but now are outside that realm, but at the same time feeling still very passionate about healthcare in the Philippines. So that's one of the main reasons why UPMASA exists, is to be sure that the Filipino doctors, especially those trained as scholars ng bayan, are able to give back. And we're able to give back in many ways. So for example, we support the UP College of Medicine in terms of, as I mentioned earlier, we're giving donations for equipment. And then in PGAs, we also even we renovated the whole pay ward of PGH. We support scholars because we have very generous alumni. We're now, I believe at this time, we have 55 individual donors of scholarships, and through a Salanga legacy, I think we have more than 100 at the moment. So the Filipino doctors in the United States, I'm speaking specifically about the doctors in UPMASA, never forget where they came from, and we always give back. We give back to the college, we give back to PGH, we do the medical missions, and we support the scholars.
Thank you, Dr. Publico. This is again another question for you. This mini conference is a joint project of UPMASA Arizona, the UPAA, and it seems to be very, very successful. Can we expect more collaboration between UPMASA and UPAA in the future? Yes.
As a matter of fact, that's going to be my the last word that I was going to say is that UPMASA and the UPAA have started the collaboration even before this mini conference, but this solidifies it. And I salute specifically Lilian Tokyap Aquino. Where are you? Who is the brainchild of this conference and who I will never say no to. And again, UPMASA and UPAA, we are connected at the hips, okay?
Thank you, Dr. Publico. This is a question for Dr. Legaspi. Is the Philippines hobbled in implementing the Universal Health Act because we do not have a Secretary of Health? Is that the problem?
The provisions and the implementing rules and regulations have been set, and I think with or without the Secretary of Health, the wheels of the Department of Health will grind, so to speak. What really stymied it is the pandemic. If you notice, less in a year's time, just about the time that they were writing the rules and regulations, the pandemic hit and everything stopped. So I think regardless of a permanent or an officer in charge in the Department of Health, I see our young DOH workers very enthusiastic in making the Universal Healthcare Act successful, and I see hospitals already buying into it because everyone has agreed that primary care, organized primary care, is the way to go for now to cover more Filipinos.
I agree.
So there's a question about the Secretary of Health. There's not, of course, that's a prerogative of the president, but I guess they just couldn't find the right one, the right mix for the cabinet.
I think it's because you keep
profile.
saying no.
Thank you, Dr. Legaspi. Dr. Legaspi, this is another question for you, another burnout question, and electronic medical records. Electronic medical records here in the United States is mainly designed for billing and less for communication among health professionals. Although we are getting better, but I believe this is the main reason for physician burnout. Are leaders in the Philippines, healthcare leaders, aware of this and how to prevent electronic health records in the Philippines to become more burdensome than beneficial?
Just to give you a background on the EMR of PGH, the EMR of PGH was created during the COVID crisis as a response to nurses not wanting to touch a chart of a COVID patient. So Dr. Homer Ko, who was a master's degree in computer science and Rao is coordinator of services, put together this system called Radish that evolved to our current electronic medical records. You're right, mainly it's for communicating among the health personnel through the electronic chart. And the billing part, we're not as strict with the requirements in the billing part, and I think our billing has nothing to do with the entry in the chart. Our billing has to do more on the completeness of government requirements in as far as payment is concerned for, let's say, PhilHealth. But true, as it became widely used among our and the coverage of the records, electronic medical records, is nearly all aspects of patient care now. We are getting complaints from our residents, our fellows, even consultants, on it becoming a little bit more tedious because as the functions increase, I think the need for safety nets for provisions for fraud and misuse come into play, and this is, I think, where the problem lies. So luckily for us, we built it from the ground up so we can modify the EMR as we go along, and we're still in the evolution of the EMR, but I'm sure one day we'll hit the right, the sweet spot. As far as burnout is concerned, there are reports from the other departments. Let's say the OB residents claim that it takes them almost the whole afternoon after their work to complete some of the charts of this patient. So we are trying to answer that with the IT team dedicated to the health records. But the burnout in doctors is the number one. We now have a burnout policy that is research-based, and they haven't identified EMR as one of them. What they have identified is still the volume of work that they need to do. And one of the intriguing answers to the survey was that they want to do more meaningful work. That's, I think, the younger doctors. Hindi na pwede yung the residents will clean the car of the senior or take care of their kids while they're making rounds. No? So I think those are the directions we're going through as far as burnout is concerned.
I have one personal question to you, Dr. Gaspi, and maybe Dr. Pupi can comment. The budget per university in the Philippines has been slashed significantly. What are we doing about that, Dr. Gaspi? And maybe Dr. Pupi can comment about advocacy to bring back the previous budget that was taken away.
That issue has come up repeatedly in media and in public fora. But as I have explained to the Department of Health, there's no slash of vital budget. No? If I may be allowed a few minutes to explain how money is given to PGH. Money is given in three tranches. No? One, a big part of it, almost 50% goes to paying the payroll, which is personal services. Second part is for operating the hospital, the MOE. And the third is the capital outlay. The personnel and the MOE are the more vital parts of the budget because they will set what we will, how many people will serve our patients and how much money we can serve them with. The capital outlay is highly variable. That depends on the buildings you need to renovate, the equipment you need to buy for the year. No? So this is a lot of times really dependent on the availability of extra funds. So we've been fortunate in the last 3 years. Our budget has been record high. 2021 being the highest at 7.2 when I became 7.2. When I became director in 2015, it was 2.8 billion. So it's a big leap. So there's no slash in the budget because for 2023, we still got 5.9 billion for the personal services and the MOE. For 2021 and 2020, we got almost the same, 5.8 billion. So I had to go public to explain that. I think UP and PGH still carry a little, carry more favor with the senators and the congressmen, and they will protect the budget. We're quite confident with that.
Thank you. Dr. Publico?
So it seems like there's no need because what Gap is saying is there's no real significant slash in the budget. Is that my understanding of what you just said? So that's
Yes.
great. So is it because most of them are your patients?
The most important is the Senate Committee head of the Senate Committee for Finance. I think he holds the purse among all of them. But the important thing about capital outlay, of course, is it's moving forward. The basal metabolic rate for healthcare are the PS and the MOE. But when you want to jumpstart programs or buildings or equipment, that's where capital outlay comes. And again, we haven't failed on a yearly basis to get what we initially asked for. Again, if I may explain, the Department of Budget and Management's role is to limit spending as much as possible. So when you submit your budget, first thing they do is they cut out the capital outlay. They don't give you anything. And then you work with the congressmen and the senators for it to be realigned. They call it realigned. So eventually PGH and UP, the whole UP system get what they ask for at the start of the budget season. So I think our name as an institution still is very good.
Thank you, Dr.
Respect.
There's just two small, quick questions here. One is, how is UPPGH training in achieving enough primary care physicians. I think the one who asked the question presumed that we're training more specialists than primary care physicians, and to achieve your problem having more physicians for the Filipinos, you should train more primary care physicians, or maybe do a specialty or a retraining of the specialists for as primary care. Have you ever been asked this question before?
Yes, so in reassessing our path for PGH, one personal realization is the vision mission of our College of Community-Oriented Medical Education is not carried over to PGH as we knew it before. No? So in PGH, we're trying to train the specialists of the specialists. No? So starting last 2, 3, we just had a huge strategic planning towards this, and that's why the first thing with the low-hanging fruit is to convert our residency programs to community-oriented community-oriented programs, residency programs, by fanning them out to the community. No? So OB is doing this, Pedia is doing this in Samal Bataan, rehab as a community-based rehab program, and to solidify that, we have increased the residence of the residency slots for the Department of Family and Community Medicine. And surprisingly, for the first time in years, all the slots are being taken. There are applicants for the slots in PAD. I remember, pinakakawawang residente sa PGH, ang family medicine, I think we look down upon them as neurosurgeons, and I'm really regretful of that, because I think they really will now play a big role in the way we roll out healthcare. And also, the Department of Internal Medicine is thinking of putting up a primary care specialty fellowship. So these are the things that we have been talking about in response. Aside from connecting, we are also increasing the number of residents.
Very, very good, Dr. Gaspi. We're happy to hear that. But one last question is, what is the impact? What is your success rate in getting reimbursement from PhilHealth? Are the physicians getting really paid for their services?
I think as far as the physicians, so the PhilHealth payment to PGH goes 2 ways. One, to the private doctor, from the private patients, PhilHealth shares, they go directly to the private doctor that took care of them. So that's in our pay wards. So there's no controversy there. But the charity patients, let's say I operate on a charity patient, I don't get that PhilHealth. That PhilHealth goes into a big pool where 4,200 employees partake at the end of the month. 65% going to the doctors and 35% going to the non-doctors. So we of course, when PhilHealth was not paying us for quite a while, there was, as in most hospitals experience, there was a lack of reimbursement. So you could see it in your bank account, it's not coming in. But now it's coming in, and I think they're trying to catch up the years that they've not been paying. So again, PhilHealth sees PGH as a special hospital, and we are getting special treatment from them. JJ Arroyo, our graduate, is one of the board of directors, so we have a direct line to the board of directors of PhilHealth, and they've been very cooperative in giving us our share. Our PhilHealth income alone is enough to run the what we call the medical assistance program of PGH, and this runs up to 1 billion pesos a year. So the PhilHealth income is quite big. And the outpatient, and now I mentioned about the consulta package of DOH, of the university. It's now earning a lot for PGH also, because if you remember when we saw patients in the outpatient department, PhilHealth did not pay anything for them, even if you did laboratory for them or did special evaluation. Now PhilHealth is paying for them, and it's coming out to be quite sizable part of our income, because we have an outpatient that serves 500,000 patients a year. So that's quite sizable. Yeah.
Wow.
Thank you, Dr. Legaspi and Dr. Publico. Now, can you just give some final talking points to say goodbye to all of us? And again, this is a great conference.
Beauty before age.
Okay. All right. So June, this has been very exciting. I started at 8 o'clock with the media track, which I also found very, very informative. I also sat through technology, of course, again, set up. They talked about artificial intelligence, robotics, and also that made my job a little bit easier. But of course, this is my favorite track because I get a chance to see GAP. Despite the Pacific Ocean, I don't even know if he's in Manila. I think he's somewhere else. But at least I'm able to, really have this kind of conversation with him and with you and with the group. And I really think that this collaboration between UPMASA and UPAA should continue. I see you smiling and I have my thumbs up too. And of course, the Pacific Ocean should never be a barrier between PGH, the College of Medicine, and UPMASA. So thank you so much, especially again to Lilian.
Thank you, Lilian.
Mabuhay ang UPMASA, UPAA in Arizona.
Dr. No.
Dr.
Yung
Legaspi.
gwapo naman, yung gwapo.
Thank you very much for having me here. It's quite challenging for me because it's 4 a.m. where I am now, now 5 a.m. But I could not miss this because I know the discussions will be very fruitful and hopefully the short time that we had enlightened a lot of you on the situation that's ongoing. It's not that bad. It was bad, but I think what I'm really saying is they should really see the young healthcare workers. It's quite inspiring to see them our graduates in DOH are increasing. More are going to public health, and this a forum like this will hopefully inform everyone attending and help us get to that goal. UPMASA and UPAA have done a lot for College of Medicine and PGH. I'm happy to have been involved with both organizations in my term as director. I have 2 more years to go. If you have any ideas after this, I can sit down with you or have a Zoom and concretize these ideas, which, as I mentioned on a few examples before, have proven to be really effective for us. Dr. Ian Soriano did the first robotic bariatric surgery in PGH on a utility worker that was 310 pounds, can barely work it. And Dr. Ian Soriano continues to be a visiting professor. Dr. Malabonga sends personal support, financial support to the program, to his baby, the patient safety unit. And more, of course, the Operation Wildfire has, engulfed the operations in the Bay Hospital, and are about ready to finish that. So thank you very much for having me here. I see very familiar faces, and I'm glad to have met new ones. Thank you.
Well, thank you, Dr. Legaspi. Guten Morgen in Germany. He's in Germany. And good evening to Dr. Publico. Thank you.
Thank you.
Thank you, Dr. Legaspi.